Hello and welcome to the topic Acute Gastroenteritis and Fluid Electrolyte Management in the Paediatrics module. By the end of this session, you should be able to define acute gastroenteritis, discuss the pathophysiology and causes of acute gastroenteritis, list the clinical features of acute gastroenteritis, list the investigations needed for acute gastroenteritis, and discuss the management of acute gastroenteritis along with appropriate fluid and electrolyte management. Acute gastroenteritis is defined as a diarrheal disease of rapid onset with or without nausea, vomiting, fever, or abdominal pain. Acute gastroenteritis, or in short, AGE, is a major cause of morbidity and mortality in children globally. Although often considered a benign disease, acute gastroenteritis remains a major cause of morbidity and mortality in children around the world, accounting for almost 1 million plus deaths annually in children younger than 5 years, or roughly 15% of all children deaths. As the disease severity depends on the degree of fluid loss, accurately assessing dehydration status remains a crucial step in preventing mortality. Adequate fluid balance in humans depends on the secretion and reabsorption of fluid and electrolytes in the intestinal tract. Diarrhea occurs when intestinal fluid output overwhelms the absorptive capacity of the gastrointestinal tract. The two primary mechanisms responsible for acute gastroenteritis are 1. Damage to the villus brush border of the intestine, causing malabsorption of intestinal contents and leading to an osmotic diarrhea. And number 2, the release of toxins that bind to specific enterocyte receptors and causes the release of chloride ions into the intestinal lumen, leading to secretory diarrhea. Even in severe diarrhea, however, various sodium-coupled solute co-transport mechanisms remain intact, allowing for efficient reabsorption of salt and water. Identifying the specific etiologic agent responsible for acute gastroenteritis rarely changes management. However, it may be helpful to differentiate between viral, bacterial, parasitic, or non-infectious causes. The history and physical examination serve two vital functions. Firstly, as for symptoms, we can gather the history of diarrhea, vomiting, abdominal pain, symptoms of infections, and changes in behavior. This helps us differentiate acute gastroenteritis from other causes of vomiting and diarrhea in children. And secondly, the signs provide us information to estimate the degree of dehydration. Some red flag symptoms and signs in children with acute gastroenteritis would be altered sensorium, bilious or bloody vomiting, cyanosis, inconsolable crying or excessive irritability, petechial rash, poor peripheral perfusion, rapid breathing, a temperature of 40 degrees Celsius or more, toxic appearance, or low body weight. Bedside investigations include assessment of the dehydration status depending on severity according to the table as shown. Workup for acute gastroenteritis should begin by using elements of the history and physical examination to determine the level of dehydration, whether is it severe, some, or no dehydration at all. Among the lab investigations that can be carried out include fecal leukocytes and stool culture, especially in children presenting with dysentery, full blood count and blood cultures where systemic infection is suspected, and finally, urine cultures. Initial management should focus on correcting the dehydration. Children with acute gastroenteritis rarely need intravenous access. Only those who are presenting with circulatory collapse due to severe dehydration or sepsis should be given 20 ml per kilogram bolus of normal saline. Oral rehydration salt is the treatment of choice in children with mild to moderate gastroenteritis. In children with minimal or no dehydration, no immediate treatment is required. If the child is breastfed, then the mother should be encouraged to breastfeed more than usual in those with minimal or no dehydration. If the child is not exclusively breastfed, oral maintenance of fluids should be given. Any ongoing losses need to be replaced with 10 ml per kilogram body weight of additional ORS, and for each loose stool, as well as 2 ml per kilogram body weight of additional ORS for each episode of emesis. In mild to moderate dehydration, children should be given 50 to 100 ml per kilogram of ORS over 2 to 4 hour period to replace their estimated fluid deficit, with additional ORS given to replace ongoing losses. For patients who do not tolerate ORS by mouth, nasogastric tube feeding is a safe and effective alternative. In severe dehydration, as it's a medical emergency, it requires immediate resuscitation with intravenous fluids. Intravenous access should be obtained and patients should be administered a bolus of 20 to 30 ml per kilogram, lactated ringers, or normal saline solution over 60 minutes. If pulse, perfusion, and/or mental status do not improve, a second bolus should be administered. After this, the patient should be given an infusion of 70 ml per kilogram, normal saline, or ringers lactate over 5 hours, or 2.5 hours for older children. Once resuscitation is complete and mental status returns to normal, rehydration should continue with ORS. How about feeding and nutrition? So in general, children with gastroenteritis should be returned to a normal diet as rapidly as possible. Early feeding reduces illness duration and improves nutritional outcome. Breastfed infants should continue to breastfeed throughout the rehydration and maintenance phases of acute gastroenteritis. Formula-fed infants should restart feeding at full strength as soon as the rehydration phase is complete. Weaned children should restart their normal fluids and solids as soon as the rehydration phase is complete. Fatty foods and foods high in simple sugars should be avoided. For the majority of infants, clinical trials have found no benefit of lactose-free formulas over lactose-containing formulas. This table shows the 3 different plans for rehydration in acute gastroenteritis. It is tailored according to the severity of dehydration, as for mild, less than 5%, moderate, 5 to 10%, and severe, more than 10%. This is how fluids and electrolytes are corrected in acute gastroenteritis. To recap what we have learned, acute gastroenteritis is defined as a diarrheal disease of rapid onset with or without nausea, vomiting, fever, or abdominal pain. There will be an imbalance between the interstitial fluid output and absorptive capacity of the gastrointestinal tract, leading to diarrhea. The cause of acute gastroenteritis in children are due to viruses, which are most common, protozoa, bacteria, and helminths. The history and physical examination are vital to differentiate between acute gastroenteritis and other causes of vomiting and diarrhea in children, and to estimate the degree of dehydration. Investigations are aimed at finding out the severity of dehydration rather than the causative agent. When it comes to management, initial management should always focus on correcting the dehydration. We have come to the end of this lesson. Thank you for your time.